Okay. Um, I'm going to be looking both ways, so I apologize if it looks like I'm not actually talking to you guys. But that's how my screens are showing up today. First, good afternoon. My name is Melisa Byrd. I serve as the Medicaid director here at the Department of Healthcare Finance. Thank you guys so much for having me here today. I had a few topic or agenda items that folks had shared in terms of wanting to touch on today. So hopefully I will hit on all of those things. If I don't, feel free to ask questions, and I'll do my best to address things. There's a lot going on in Medicaid right now, as you all know. So what I'll do real quick or start off the presentation is just really more of Medicaid at a glance here in the district. Talk some about what is new in, we're going to call it fiscal year 2026. Then I'll move into some of the future changes that are coming up because of the One Big Beautiful Bill Act, which you will hear me reference it as OBA or OB3. And then talk a little bit about how to get involved with the work here at DC Medicaid. And then, of course, questions and answers. If you have questions as I go through things, feel free to maybe put them in the chat. I'll do my best to monitor and or just take yourself off mute and ask the question. So I think most everyone here is familiar with the Department of Healthcare Finance. We administer the public health insurance programs across the district, which includes Medicaid and the Alliance program. Medicaid is a federal and state partnership for people and families with low income and or with disabilities. Generally speaking, for the past several years, the Medicaid program in DC has provided access to coverage for about 40% of residents. CHIP is the Children's Health Insurance Program. I won't typically refer to it separately because we have our Medicaid program our CHIP program is just Medicaid expanded to cover additional kids. So we kind of use Medicaid as an all-encompassing term. When you think about our budget or spending, our budget is just a little over $5 billion, and that includes both local and federal funding. The majority of our spending goes towards children's health services, behavioral health, and long-term care services. This data was pulled back in January, but for fiscal year 2024, and you can see around the pie that adult LTSS or long-term services and supports is about 34% of our spending, which accounts for about $360 million in local funding. And then you see the largest portion is other spending on adults that's not long-term services and supports. And then you see the breakdown of children's spending and spending for adults, mental health, and SUD services. So I noted already that about 60% of the services cover children's health services, behavioral health or mental health and substance use disorder, and long-term services and supports. What I think is important to highlight and that you all likely know is that many of these services from like a federal perspective are considered optional services, meaning it's at the state Medicaid program's discretion to provide them. And I think it's important to highlight this because I think what is deemed an optional service, many of us would not actually consider an optional service. And these services include mental health, substance use disorder services, community living supports like personal care, home health, home adaptations, and then institutes for mental diseases. And many of the optional services that are covered through Medicaid aren't found in other health insurance coverage programs. They're not covered by Medicare, and they're typically not covered by private insurance either. As part of like Medicaid at a glance, I wanted to touch on some of the eligibility issues that were raised and that I know is really important and pertinent to the work that you all do, and that is continued eligibility or annual renewal, Medicaid eligibility renewal that's necessary to ensure that folks remain eligible for the program, enrolled in the program, have access to the services, and then the work that you all do that often has a direct impact to your ability to be paid timely. I think most folks are aware that we had a legacy system, ACEs, that we did sunset in October 2022. I'm going backwards and giving a little bit of background as context for some of the things that have been going on more recently from an eligibility perspective. Most folks who receive long-term services and supports are in an eligibility category group that we call non-MAGI. That's the non-MAGI. So pardon me for the acronyms. And when we shifted from ACEs to District Direct or the DCAS system, we had to convert the cases from the legacy ACEs system. And what that meant, which was particularly kind of an extra level of effort during the Medicaid unwinding time period, is that in order to convert the cases and bring them fully into the new system, we had to get additional information from those residents, which means we had to do paper applications and collect that information. So that was a one-time requirement for folks who were already enrolled in the program. The good news is that nearly all of the long-term services and supports cases have been converted and are within our District Direct system in the way that we expect them to be. We have something called the Partner Portal through District Direct. That is where long-term applications and renewals can be processed, and is obviously a place that you all use for renewals and so forth. And then in September 2024, so just a little bit over a year ago, we implemented a simplified renewal process for most of our home and community-based services waiver enrollees. We were able to extend this simplification to nursing facility and other facilities this past summer. The one exclusion we have in terms of folks that can't fall under the simplified process are those individuals utilizing spend down as their entry point to Medicaid. We have other changes supporting greater efficiency, really different interface changes, like we have an interface with the Department of Disability Services system so that they can upload level of care information electronically versus having any kind of paper exchange. And then we also have been able to automate the patient payability forms. You might know them as the 1346 or 1445 forms. So those are two, I think, improvements that we've been able to make along the way. And one of the reasons for the simplification and the streamlined long-term services renewal process is we certainly, and you guys know this or feel the results of it very directly, is that we've had historically, it's been challenging to timely process the applications and renewals. And we were tracking some of the issues, particularly as we received concerns about payment from nursing facilities, where we were really trying to get out of a backlog. We realized we just had some systemic issues that weren't going to be resolved by continuing to do what we were doing, but possibly with just more staff. And so we were able to develop and implement a streamlined renewal process. And as a result, we are seeing a really high passive renewal rate now for home and community-based services. And passive renewal means is what most MAGI, most folks who are in Medicaid but not through LTSS, we have enough information and electronic resources we can ping and confirm someone's eligibility without them having to do anything themselves. So like we run that process, and then if we can confirm eligibility, instead of getting a renewal notice that says, please renew, we can send it out like hey, your Medicaid has been renewed for the next year, and the resident doesn't have to do anything. And so our goal is getting to the point where we have passive renewal, or sometimes you'll hear it ex parte, for as many people in the non-MAGI category. Seems like it should be an obvious one, particularly given that there's such little churn in this group. But it is some positive steps that we've made over the past year. You can see on the slide before you that we have less than about 50 people per month that are not a passive renewal. So that means they have to have some active work done so that we can process the renewal. And then overall, we're seeing about anywhere from a 50 to 75% passive renewal rate for facilities. So I hope you guys are seeing that effect in your day-to-day work as well. Where we're focused on now is really we have some long outstanding facility applications and cases, and we are working to resolve those. Many of you have standing meetings with my staff here to work through these cases. And in case you don't, or you have issues, and you all will receive the PowerPoint later on, you can reach out to Anthony Proctor, who is our manager for what we call the Medicaid branch, which has the responsibility for long-term care applications and renewals. I'm going to switch to what's new in 2026. I don't see any questions in the chat for now. And there are so many changes. I'm going to do my best to keep them as simple and straightforward as possible. What I'll start with is what has and is happening right now. If you follow the budget, the fiscal year 2026 budget process, you know that the district is in a challenging fiscal environment right now where costs continue to go up across the city in many sectors, but certainly in healthcare and in Medicaid specifically. But the city's revenues aren't keeping up with those costs. So the simple way to do it is we have more expenses than we have funding. And as a result, we had to make some significant changes to the Medicaid program for this new fiscal year. The first significant change focused on our local only program, the Alliance Healthcare program. I was asked to focus on Medicaid, so that's what I'll do today, but I'm happy to answer any questions about the Alliance program changes. What's coming up in just about 3 to 4 weeks is that the Medicaid income eligibility for some adults will be changing. We cover most adults today up to anywhere between 215 and 221% of the poverty level, which for, I believe, a single person is about, I can't recall off the top of my head right now. I'm sorry. But what it will do is change to a single adult who has an income of $1,800 a month or less will remain eligible for Medicaid. But if you have income over about $1,800 a month, you will no longer be eligible for Medicaid based solely on your income. For a parent or for parents in a household with 4 people, so 2 adults, 2 children, that you can make around $3,700 a month or less and still remain eligible. But if you make more than that $3,700, you will no longer be eligible for Medicaid. The positive piece for this is that while we're making changes to Medicaid coverage and eligibility, we do have a new coverage option in the district called the Healthy DC plan that is administered by the district's Health Benefits Exchange Authority. And about 90% of the people who will lose Medicaid eligibility will be eligible for the for the Healthy DC plan. You may have heard it referred to as the basic health plan. And this is no cost, no premium, no copays. The benefit package is a bit different than Medicaid. There are no long-term services and supports covered, no vision, dental, or non-emergency transportation, but most everything else is. There's a small portion, about 10% of the population, that will lose Medicaid eligibility that will not qualify for a Healthy DC plan. That only takes you up. You have to have less than 200% of the income level. But there are plans in the private market, the private plans on the DC Health Link that will be available for residents as well. What I think is important, particularly for you all, is that there are no changes for seniors. So that's folks 65 and older, individuals with a disability, and residents receiving long-term services and supports. So these changes will not impact those individuals at all. And for us in long-term care in the district, that includes folks enrolled in one of our 1915C waivers. So that's the EPD waiver, the individuals with developmental disability waivers, and the individual and family supports waiver administered through DDS. individuals in nursing facilities or ICFs, and residents participating in the PACE program, or the Program for All-Inclusive Care for the Elderly. Rob, I will come back to your question in a moment.
Sure, thanks. Thank you.
No problem. Actually, I'll pause right there and answer. So if there, your question, Rob, is if there are 50 LTSS renewals that are not passive, how many are processed as passive? I don't have the number, but the percentage rate is 50 to 75% per facility. So I can see what the number is.
Like 70 to 100? It's probably something like 70 to 100.
Possibly. I cannot do the math that fast, but if we're doing 90%, you have 50. I will go with that, but go ahead.
What's the difference between the 90% and the 50 to 75%?
I think the 90% is supposed to be an overall, how we're looking at it overall.
Is that for all Medicaid, and then the 50 to 75% is for long-term support services?
The 90% is for HCBS only. So it would not be folks, it would not factor in people in a facility. It would just be the waiver folks. So EPD waiver or the 2 DD waivers. And so when you look at the less than 50 per month, that's for that's the remaining out of that 90%.
Okay.
And when you get to that third bullet, it is specific to facility renewals. And that's where you see a lower passive rate.
Sorry if I'm a little uninformed, but what's a facility renewal?
That would be like a nursing facility or someone in a nursing facility or in an ICF. But the EPD waiver ones,
okay.
It could be someone in an assisted living residence or receiving, home and community-based services while residing in their home.
Non-HCBS would be a facility.
Yes.
Okay, thank you.
No problem. Other changes in fiscal year 2026 that hopefully you're fully aware of is the work that Benjamin Begbie as our long-term care director is leading to really take a more person-centered approach to ensuring quality and long-term services and supports. The way we've been organized internally and our approach has really been to look at our services almost like through programs or silos. So you have nursing facility services, you have the waiver services, and now we have our dual choice program and PACE. Our goal is really to make sure we want, if any resident is receiving services through a waiver program or from a nursing facility, or they're participate in the dual choice program, we want their experience and the quality of the services they're receiving to be equal. And their expectation should be, I will receive the same level of service across the board. And that's a different way for us to align our work internally and our approach, and really looking across the continuum of programs that we offer versus kind of looking at things fee for service or managed care. And so in doing this, through Benjamin's leadership, we have formalized an oversight monitoring policy that's guiding our staff here. This policy establishes procedures that help us assess provider performance. Obviously, our guiding principles or regulations come from the federal and district governments, and really looking at how we can better promote accountability and really continuous service improvement, because all of us always have room for improvement. Internally, we've got a series of tools that have been developed to assist staff. We've implemented a continuous quality improvement plan, and then also set compliance thresholds or expectations of where we expect our providers to perform in meeting our expectations. And then we've set a process or a pathway for how we can escalate and enforce for escalation and enforcement when we have, this isn't like a one-off issue, but when we have fairly persistent or severe deficiencies that we continue to see within a particular provider. What you might be more familiar with is on the self-reporting side that was fully phased in at the start of October of this year. So we've moved to self-reporting from providers versus always having our staff going on site to pull all the information. The goals here are really to enhance, and be more efficient in our oversight monitoring process. Obviously, shift to self-reporting, which we hope is more agile and efficient for everyone involved. And most importantly is really have more real-time data on what residents are experiencing as they receive LTSS through the Medicaid program. You have monthly self-reporting now by providers where you are asked to submit by the 5th business day of each month. We've standardized checklists internally that makes, our goal here is to have consistency. So regardless of who from DHCF is looking at your data, they're going by the same standards and expectations. So you have transparency into what we're looking at. And then streamlining our oversight procedures. So you see this is a lot of process-oriented changes, but again, it's really to promote the efficiency. It's also to promote transparency so you know what to expect from us. The process to implement has been ongoing for the past year. And really, and I think I already spoke to the outcome, we're really looking for that transparency on both sides, not just from providers, but from us as well. And using data as much as possible to drive our oversight and monitoring. And then again, it will give us insight from an agency perspective to see how are we performing across all Medicaid LTSS and have a more holistic viewpoint of what's happening for our residents. So now I'm going to go into future changes, and I will probably go quickly because I think I'm coming up on my time. If you followed the news over the past several months, really through spring and summer of this year, you know that we have a lot more changes in store for the Medicaid program it really started on July 4th, but the more impactful ones begin in 2026 and beyond, really up to like 2034 from the One Big Beautiful Bill Act. The President signed it on July 4th. This is the bill that resulted from the congressional reconciliation process, which allowed them to move some significant policy changes fairly quickly. I mentioned already the changes to the Medicaid program. There's a ton of them, and they have different dates. Some of the earliest ones became effective on July 4th and on date of enactment of the bill, and others don't come into play until as late as 2034. I would say the most significant changes and those that are coming up a little bit more quickly are those related to what we call the Medicaid expansion population, which I will talk about in a little bit more detail. Over 2026 and 2027, and here I'm talking more calendar year, it's really the changes are focused on adults and will have little to no effect on folks who are 65 or older and or have disabilities or are eligible based on their disability. The next change that comes up, and this has a small impact only in terms of numbers of people impacted. There are eligibility changes to the definition of who is a qualified immigrant. So the takeaway from that is there will be fewer people who will be eligible for Medicaid. And this is so for folks that are considered, there's a lot of folks who get Medicaid eligibility because they are deemed, they have asylee status. They're narrowing those definitions, so there will be fewer people eligible for Medicaid through legal immigration status. The next big date that's important is January 1st, 2027, which is when the Medicaid work requirements become effective, where some adults, again, outside of long-term services and supports, will have to recertify their eligibility every 6 months instead of every 12 months. And then Medicaid retroactive coverage will be limited for some groups to no more than 1 month versus 3 months that's allowed today. I won't go over all the work requirements, but I did want folks to have this accessible. Work requirements are for the supposed able-bodied adults. In the district, it's adults are ages 21 to 64. You'll see in the legislation, it says 19 to 64, but in DC, our kids are classified up to through age 20. But the eligible population are those who do not have dependents. So we're talking about childless adults in the District of Columbia who are eligible by virtue of their an adult without dependents, ages 21 to 64. There are several exemptions and exceptions to the work requirement, and you'll see more detail in the coming months, but I also wanted everyone to have this in front of them. This is explicit, taken, I think, almost verbatim from the legislation, but you can see individuals considered medically frail. You see the list there, folks who might be participating in a substance use disorder treatment, and so forth, folks who have Part A coverage. But again, for the district, it will really be focused on the individuals who are what we call childless adults. You will start hearing a lot more from the agency about work requirements in 2026, in the calendar year 2026. The changes really are significant. What we will have to do to implement this spans, our policy work, our operations work, outreach. It looks like, I should have updated this, that the federal government's going to define medically frail versus deeming that to the states. We have changes to our integrated eligibility system. And most importantly, we need to make sure that our residents understand what a work requirement is and how this may impact them. The key takeaway to this is no action is needed at this moment, but more to come in 2026. Quickly, we encourage you or hope that you'll get involved in DC Medicaid through our Medicaid Advisory Committee, the MAC. It's formerly called the MCAC, but new federal law or rulemaking made it the MAC. In October, so just 2 months ago, based on requests from our partners, we are reforming the Long Term Care Subcommittee. Rajan Thomas, that many of you probably know, has agreed to serve as chair. He is from the Home Health Association. We are also working to get a co-chair from the facility side, so like from a nursing facility or ICF. So we have representation from both community and facility base. And also it's always helpful to have a co-chair to take on some of the work required of a chair. What we plan to do is really look at the following components to develop our agenda topics. So we'll have, and this is what we do with all of our other subcommittees, discussions or conversations with the chair and co-chair on topics of interest. We always talk about what could be really beneficial to the agency in terms of input and feedback from our partners, and then any topic that's been possibly submitted to our full Medicaid Advisory Committee, that if it falls in like the purview of LTSS, then we would have that referred to the subcommittee. The first meeting will be this winter being somewhere between January and March 2026. And there will be quarterly subcommittee meetings thereafter. The first subcommittee meeting will be really talking about the goals and structure of that subcommittee and where the work will focus. If you're interested in joining the subcommittee or being on the listserv, you can always just email me, but you'll be more successful, get a quicker response if you email DHCF MAC and back at dc.gov. Regardless of whether you want to participate in the subcommittee, if you have ideas or areas where you would like the subcommittee to discuss or focus on, you can also submit those. Another way to get involved is we do have bi-weekly meetings on Wednesday afternoons at 2:30 to really touch on changes that are coming forward in the program. They've largely been related to eligibility. We started this during the Medicaid unwinding process. It's now evolved into the various program changes happening with Alliance and Medicaid this fiscal year. The next meeting will be the 17th at 2:30. If you ever want to see the meetings, all the recordings are on our website, etc. And the next is really informational for you. We do have monthly resident focused eligibility meetings as well, that any resident is, welcome to join us. We try to keep it resident only, so folks are most comfortable bringing forward their questions and issues. Another way to get involved is, sharing information about what's happening with DC Medicaid. Right now, with all the changes, as you talk with residents, make sure that they know that there are changes to adult coverage for Medicaid and that some adults will no longer be eligible in 2026. Outreach is underway from both DHCF, the managed care plans, and the health benefits exchange. If someone says, I got some notice, I don't understand it, tell them to give us a call. Folks can also go into their district direct account to see notices and other updates. And you can tell folks, if someone says, I got a notice and I'm losing coverage, please let them know there might be a no cost coverage option for them, and they can go to DC Health Link. Children and pregnant people are not impacted, and work rules do not apply yet. They begin in 2027. And so with that, here's my contact information as well, and my cell phone number, and then our website and other places to contact us. I'm going to just stop sharing so we can have a fuller screen. And hopefully I have stopped sharing.
Yes.
Great.
Thank you so much. Sorry, Melissa, what was that?
No, I was just going to say, I appreciate the excitement on the subcommittee. And on what number should they call? Let me pull that up. We can always call if someone has a question about their eligibility or they don't understand a notice. I'm going to put it into the chat so folks can see it. But they can call our we have a call center that folks can call. Okay, there you go. And if it's okay, I'll answer the next question. Sally, it's good to see you. How are we tackling issues related to past reimbursement owed, but perhaps for a variety of issues is not showing up in the payment system for certain individuals and facilities? I believe that's the work our team is doing when I reference the long-standing unresolved cases. But Sally, if you know of particular issues and it feels like no one is addressing them, please reach out to me directly and I'll follow up with the team on that.
Great. Thank you so much, Melissa.
No problem, Sally. It's good to see you. Are there any other questions?
Melissa, I was hoping you could speak briefly to some of the responsibilities of the chair of that MAC Long Term Care Subcommittee, in case we have folks who may be interested or know colleagues who would be a good fit.
Sure. The main roles and responsibilities is that, kind of simply put, you are definitely the face of the subcommittee. You lead the meetings that we have and facilitate those and any kind of follow-up that may come from it. We try to make it as light a lift as possible. We have staff support. So like our staff will set up probably like a planning call, like we mentioned, have the discussion with the chair and co-chair. What should we tackle? What should we talk about? What do you want to talk about? Those things. Our staff will develop the actual agenda then. We do all the communication out. So the logistics and the planning components, we try to, take that on or execute it on your behalf. And same with any kind of like meeting notes, the follow-up actions, things like that. When it gets into like more of a formal recommendation, this came out with one of our subcommittees this past year. Because they're making recommendations to the agency at that point, we might, as staff, will step back a little bit and let the chair take that lead a little bit more in the forefront. But for the most part, it is your commitment of time to the quarterly meeting. I would say quarterly planning meeting, and then anything that comes up ad hoc in between those. But we really do try to take some of the logistical stuff and follow through off your plates for that.
That sounds great. And thank you for sharing this information.
And I should say too, like the chair also participates on the MAC. So on the Medicaid Advisory Committee, we meet roughly one evening every other month. And there's a reporting out function that occurs as well.
Great. And are there also spots open on the committee itself in addition to the chair?
We just filled spots. We usually have them open for an October 1 term. And so usually about June or July is when we make the call or solicit applications and then pick through that process. So right now, no, we just filled slots, but in just a few short months, probably about 6 months, there'll be opportunity again.
Great. So I don't see any questions. Folks, please feel free to unmute or enter your question in the chat. But I did want to ask Melisa, over performance oversight hearing season is coming soon. What are ways that we can be most helpful when we're sharing testimony about our experience with your office when these opportunities are coming up next year?
I mean, how can you most be helpful? I think it is always appreciated to get the good and the bad, right? So if you had any positive experiences, it's nice to hear it. We usually hear the things that aren't going well, which is appropriate. It is appreciated if we know in advance about the issue. So most of the time, we've probably been working with you or any other partner because if we don't know about it, there's not much we can do. We can't really do anything about it if we don't know about it. So any advance, like a heads up, we appreciate, like having the opportunity to engage in advance and try to resolve whatever issues there are. But other than that, I mean, I don't want to give too much because that is really your opportunity to share, about your experience with the agency, good and bad. That really, you need to highlight what is or isn't working with you all and make sure that that's on the record.
Thanks, Melisa. And I see Neil has his hand raised. Please go ahead.
Hi, Melisa, and thank you for recognizing my hand, Makeda. Question. I've emailed you about Melisa to present this presentation to the Long Term Care Coalition next week. If you're able to do that, or the appropriate person, if you're not able to do it. I'm also wondering if our coalition has monthly meetings. I'm wondering, and maybe it's John Thomas, maybe if someone from the subcommittee that's being reconvened can join our monthly meetings and give a little update, because we usually have Leading Age, AARP, SEIU, and other organizations that are involved give a 5 or 10 minute update. And it seems like this could be a great opportunity to share information on these meetings.
That makes sense. And Neil, I'll follow up on the invite for next week. And I definitely think whether it's a staff person kind of reporting out so folks from the coalition know what is going on at the subcommittee meetings or where the focus is, that'd be great. I think ideally it'd be the chair or co-chair, but we can certainly, I think it would be great to have that natural connection with the coalition, because in the past, the subcommittee kind of rolled into the coalition or something, or vice versa, or somehow. And I know we don't want to be duplicative in efforts. And so the more that we can kind of share and make sure everyone's informed, I think is really the best thing for us. So I appreciate that.
Great. Thank you. Thanks for all the work that you folks are doing.
No problem. Thanks to you all as well. It's just tough for everybody right now, I think.
Absolutely. Melisa, we so appreciate the hard work that you and your team at the Department of Healthcare Finance are doing on behalf of the residents of the district. Thank you so much for being here to share this valuable information and for sharing your slides, which I'm happy to share with all of the attendees here today. thank you all for joining us during your lunch hour and for your helpful questions. And please feel free to reach out to myself or Melissa if there are any other questions that we can get addressed for you. I'm going to go ahead and close out our webinar today. And again, thank Melissa for sharing her time, and looking forward to having more conversations with you, Melissa, and to staying engaged with all of you here.